But just to introduce our project, I know most of you have been here many days, but we have a few new faces. So welcome to those of you who have been here and welcome to those of you that are new today. But we are a learning community. We focus a lot on neonatal abstinence syndrome, but more specifically on neonatal opioid withdrawal syndrome. We know we have record rates of opioid use in the United States. It's an epidemic, and we're looking to learn more about how to better serve families affected by this. We're a community of early intervention providers supporting children and families, and we use the ECHO virtual training model. Thank you, Drake, and that stands for Extension for Community Health Outcomes. You know, our key tenets are we promote knowledge and expertise, health equity. We really consider ourselves a bridge between health and education. And we say that it is a bi-directional, that we bring in speakers to talk about specific topics in which they're experts, but all of you are experts in your own communities and in the jobs that you do, and we learn from you as well. So it goes both ways. Next slide. And again, these are the key tenets. We use technology. Echoes are always over an online platform. Not a surprise anymore with Zoom, but it was innovative before everyone was using Zoom. We really are using best practices to reduce disparity. At the end, we always do a family story. The medical field calls it a case study, but we call it a family story. And please, please, please provide us data. Drake will send out, or Chimay Lee will send out, but Drake's also analyzing the data to know, did you like the session? Did you get something out of it? What would you like to learn more about? So next slide, please. We are almost done with our series. Today is December 15th. I can't believe it. And thank you everyone for your patience. We had to rework the schedule a little bit. Today we are very lucky, and I'm going to introduce Sameerah to talk about birth health and well-being for African American Babies Coalition projects. We've had Sameerah before, and Sameerah is just a wealth of knowledge and information. And I'm going to introduce her a little more in detail in just a bit. And yes, we had to reschedule a session. We needed to fit it in before the end of the year per our grant. I know next week, many of you may be off. If you're not, or if you're off and need a break, we will have a session next week. December 22nd, we rescheduled our opioid crisis in Minnesota and social determinants of care. Otherwise, we will have it recorded, but it is really great if you can come. Everyone is welcome. Bring a friend, bring your whole family if everybody's home, and we can all participate. That really was our best attempt at rescheduling. All right, next slide, please. All right, so here is our agenda for the day, and I think we're doing just fine. And I want to save plenty of time for Sameerah. So I want to welcome Sameerah back. Thank you so much for being here. Sameerah is director of the Wilder African American Babies Coalition and Projects, and is the program manager for the Integrated Care High Risk Pregnancies Initiative. We've had Sameerah multiple times before. Sorry, my computer's squeaking at me. And has always been a popular speaker, and really has imparted us with a lot of wisdom and knowledge. And we just really want to welcome you back, and are so glad to get to hear your presentation again. So welcome, Sameerah. With that, I'll turn it over to you.
Good afternoon, everybody. Again, I'm going to say I love the snow. I just don't want to be out in it. So I'm going to begin a little bit different here, and want to try something different. In regards to the opioid, AABC has always been a part from the beginning, looking into, talking to, and knowing that this is a really important issue in the African American community, and that's why it is so important to discuss, make the community aware of social determinants of health, what it is, what the causes are. Next slide, please. We're going to talk about a think tank. That's really how we do our work. And this year, 2023, I'm building it out a little bit more within our projects. Bringing the groups, the community groups together to discuss really important matters. And one of them that I'm really looking at right now, I know you guys have this in your, so I'm not going to read it verbatim. One of the things that I'm really looking at is young mothers, social determinants in health, and the causes of incarceration. So that's where the think tank will go in 2023. Next slide, please. So some of the strategies we use is listen and acknowledge and communicate and link messages, concentrate and focus on solutions. We do this work because addressing morbidity, leaving no one behind, including incarcerated birthing mothers, is an ethical issue. Next slide, please. So we can all do this by beginning with everyone's awareness of adverse childhood experiences. I know all of you know all about it. You have heard about it. We need to keep talking about it, and we need to keep integrating it in all of the work that we do. A lot of people that we work with every day have no idea what ACEs are. And so we just have to keep that is one of the easiest tools to help and move our community along. We also know that ACEs that we have in childhood continues with us, most of us, throughout our adult life. And we are affected by it in different forms. It shows up and in different degrees. Next slide, please. So by dialoguing and leaning into the active work on ACEs and social determinants of health, as I said, it could mean using tools such as surveys and questionnaires that go along with it. We already know there's a questionnaire for ACEs, but using surveys that are not invasive to help the community or person talk about it. We can do collective actions that enable us to become more innovative with the tools, active partnering with community and possible increased changes with preventive and interceptive implementations. That's what I'm wanting the think tank to look at. Most importantly, it is easier for people to understand and devise a way of tracking their own triggers and avert unfortunate behaviors. And you remember that I talked about young women and understanding social determinants of health, understanding where maybe some of their insecurities may come from, to help them understand the triggers to address it before they're faced with incarceration. Next slide, please. Now, I want to also say that we know, everybody online here, that with social determinants of health and some of the pain that we carry, that we know that teens look for a way of feeling better from escaping from that pain. And I believe that, and the evidence shows that from a very an age of like 13, 14, if you start talking about it, it means that they can understand it. They might be able to figure out what group is not the group that they should be in, that might be leading them that way, what might be pushing them toward drugs, what might and where can they go, possibly the school social workers. And I'm saying possibly because there's a slide that I want to share with you guys at the end where we had 30 young teens yesterday. So that's why you hear me saying a lot of maybes, a lot of possibilities. Every teen is different, but we know of certain things that we can address at a young age, and so that they can kind of get it and put the puzzle together. And us working together and figuring all this out, it can be in different silos, workers, advocates. It increases good for all of us. Next slide, please. So we, AABC, African American Babies Coalition and Projects, we are in the work of encouraging new methods that demonstrate best practices which combat systemic racism and better health outcomes from birth to adult. So I'll explain that. I believe it might be in the next slide, please. It's not this slide, but as a community, if we are serious, not wanting to be part of the problem, if we're really serious about this, like we're not getting up every day, going and collecting a check because that's how we're going to feed ourselves, but we're going to collect a check and love and commit what we're doing so that we can be we can individually do this, or we can do it as an organized force to address those systems that compress racism and hold them accountable by name, not to be afraid to call it what it is, breaking the vessels of biases responsible in contempt and determined to influence transformation. Next slide, please. So this is some of the work that we do. Can you just, is it me or can you just stroll? I think I have 14 on there. Can you stroll, Drew, or no? Go back. Okay, I left some, we have about 14 projects, but here is some of the supportive environments that we work on. We develop curriculum for healthcare workers, advocates, family, friends, and neighbors, and licensed childcare providers to provide appropriate and sensitive cultural care. In other words, with the group that I had, I asked the question, have you ever went for your prenatal care and not feel welcomed and not wanting to go back? And the heads show, they shake their heads. So we know this is for a fact that people have to be appropriate and sensitive. And I know it's hard, but all of us have to lean in if we don't know how to do it. And especially because Minnesota is very cross-cultural and there's a lot to learn. And it doesn't matter what culture you come from. I know I learn every day. We also built in and are still building in early childhood libraries. So when we talk about equity, we don't want it to be like a child has to get sick, go to the hospital, and then get a book. We feel that the best place to reach parents and children is at the child care center. It's not like it was when I was growing up. We could walk a mile to a library and pick out a book, and my mother wasn't with me. Sometimes I was walking by myself. We can't do that. These parents do not feel safe. So the best thing now is we have built in a library at the CDC for Wilder. We have one going in Maxfield. We have another interested one, school, Agape, where the children and the mothers are, because we want to promote reading. We want to promote access to books. We want to promote that our mothers and our children understand equity and justice. We have Dr. Artika Tyner, she's a professor at St. Thomas, and she's a book writer. She's awesome. She is the one that comes into our libraries, reads to the children. Whenever she has time, she schedules it with us. We are really big in having that reading time, having the child come in, pick their book. They stamp their own books. That we have little library cards for them that are fake. We ask the parent to read to them at bedtime and to bring it back the next day. We do it as a library. We're doing it because we want to also show responsibility. And it is now, we're on another stage of what if the parent has reading issues, and we'll work that out too. We have the yearly Black and Brown Birthing Summits. This year it was attended by about 171 people, and they really loved it. We do the partnership with St. Paul College Bound and distribute our baby bags for mothers, and we're part of that committee that helps in that work. So you understand, it's about reading, it's about moms, it's about babies, it's about economic stability, which is the St. Paul College Bound that opens up savings accounts for the children. We look at our work and work with partners that look at the families very holistically. We have action luncheons. We partner with the March of Dimes. That's usually 2 times a year. We host community trainings for Brains Are Built, parenting in a non-formal way. I've already said that with the St. Paul Promise neighborhood. Who wrote that? Okay, Jen. And so those are some of the things that we do. Next slide, please. I want you to go back one, which I think is important for me to say. We developed 2 curriculums. One is called Birthing Fruitions, a 5-prong series for healthcare workers. And we're going to be adding in a piece on mental health and incarceration. We're looking to do that with new funding. And we also wrote another curriculum called, it's actually 2 in 1. One is It's All About Me. It's for FFM providers working with children. And it goes through all of the issues of during especially these hard times with, it could be finances, it could be parenting, it could be food, all the different things that the families are facing. We want our legal and unlegal providers that are taking care of children to be able to work with them. And then we also have the Moving Beyond Crisis, where we're training all of these different silos again to be able to know how, if they're doing home visiting, to go in and work with the families. So the Birthing Fruition, of course, is part of our doula. Breastfeeding is part of, we make sure they have their CPR. We make sure they understand historical trauma. It's like 5 different things we do. They do get the training on the It's All About Me crisis. That's one curriculum. And then the other one is full, and it really has both of them have home visiting from a cultural perspective. But the Moving Beyond Crisis curriculum, they hear from 5 different cultural groups on what they want us to know about them, not what we think we know. What do they want us to know? Next slide, please. So I'm going to make a statement, and then after each statement, take a minute in your thoughts. These are some of the statements and questions we had at that teen forum that we had. Next slide, please. So the way we went about it, we asked them to listen for themes, the discussion, challenges, and opportunities to better outcomes. That's what we were really hoping that they would get out of it. We dialogued on prenatal and labor changes and naming their pain and talking about healing and sharing their stories from their experiences. We talked about, do they understand where the health disparities are in the American-born Black, Brown, and Indigenous mothers in Minnesota? And we asked them if they knew, why do you think they occur? And then we talked about, let's talk about perinatal, prenatal, birthing, delivery, postpartum, follow-ups, depressions, and referral. Next slide, please. So now we're going to engage with you online. Put in the chat what your answers are very quickly. I don't have a lot of time. Andrew, how much time do I have left?
It's Drake, by the way.
Oh, I'm sorry.
Just wanted to confirm. And until about, you have about 25 minutes, 25 minutes.
Okay, let's see what we can get through here. Next slide.
Yeah.
So what do we need to know? Of course, we need to know everything about climate change and all of them. Those are very, very important. But here's where we're going. Next slide, please. Something's missing. What are we missing? Next slide, please. Here's your first question. Why do challenges in high-risk pregnancies fester in communities of color, Indigenous, and underserved communities? You can go to the chat. Let me know. Drake, can you read them as they come in?
Yeah, I can read them. Yeah.
Are they not playing with us, Drake?
Oh, sorry, my computer got a little stuck, Sameerah. So you want them, why do challenges in high-risk pregnancies fester in communities of color, Indigenous, and underserved communities? Someone put in intergenerational trauma. Wendy, Molly, limited access to healthcare. Kim, not enough resources, lack of access to services, support education, intergenerational poverty. We have another one. Limited services. Sameerah, one of these, I mean, a lot of people are speaking to access. When you asked the group of young women with whom you work, did you say, when you asked, have you ever, I forgot what the question was, but it was something about feeling welcome, I think. And did you say all of them said they'd had situations where they hadn't within healthcare? I just want to make sure I heard that correctly.
Let me put it this way. The heads were shaking and no one said opposite. So
yeah,
we take it where it's at, right?
Mm-hmm.
I bet if we did separate surveys, we probably would get more information. Okay, so I'm going to go in the chat because I want to see.
Go ahead. They were good.
So all of them are correct, but there's one thing I was looking for. So I want to stretch it a little bit. Why do they have limited access? Why is there intergenerational trauma? Can someone say, why do they have lack of access to service, support, and education? Who could go a little bit further with me? Because all of them are correct, but there's a reason.
Sameerah, are you getting products of systemic racism? Is that a part of it?
But why did she jump in? Okay, I want everybody to know that is so Teresa. Teresa is one of my staff. She is my assistant. Yes, Teresa, but it's more systemic racism. It is a system put in place where some will have, and you're going to be surprised at some of the statements that the young ladies say, have shared with us. I'll share that at the end. But why are there limited resources? Why is there systemic? Okay, let me back up. Rewind. Systemic racism only fits certain people, certain cultures, because the word is racism. Now, I didn't say discrimination, right? Because we all face discrimination, but the racism is a made up, I think all of you know this, a made up system. And therefore, the communities of color that are not white will have the disparities. Does that make sense, or would somebody like to challenge that? Should I go to the next one? We can. Thank you, you guys, for answering that. Next slide. Oh, 2. What are the causes, or what are some of the causes of premature babies, maternal illness, anemia, high blood pressure, diabetes, drug, alcohol issues, maternal death? Go to the chat, please. And then in your answer, you can write if there are specific things we could do to reduce them. Wendy, poor maternal health. Would someone else like to jump in? Lack of help
healthcare access. Next slide. I mean, not next slide.
Someone else want to answer? Lack of proper nutrition. Someone else?
So all those things
Need more education to talk about health risk.
So I am
Going to give some language to it. Lack of affordable healthcare system. Okay, put that one back up. I wanted to see that one. I'm going to go in. I didn't have it. Lack of affordable healthcare as a result of systemic racism. We could increase agricultural sensitive healthcare. So all of them are right. Here's the best way to say it. If you are facing disparities, food, clothing, housing, healthcare, violence. If you're facing all of that, that is definitely going to bring your blood pressure up. Those are stressors, right? The drug, alcohol issues, those are for some people that's self healing. I'm going to do my own self-care. I'm going to do it in this manner. Okay. Premature babies a lot of times is because of poor health care, high blood pressure, and all the other toxic stresses that go on in their lives. Okay. I was a preemie and my parents were smokers at the time. Ouch. You want to say more? Did your parents continue to smoke after you were born? And have you had any effects of that you know of?
And you don't have to answer. Got you. Thank you for sharing. Does anyone else have statements
they'd like to say? Should we move on? Next slide, please. So talking ownership and gaining new knowledge. Next slide, please. So we asked them what was their choice of care during pregnancy, because just wanted to know if they knew that there were many different options. And no, they did not know of different options. Most of them just said they went in the hospital, and then they talked about the bad care that they got in the hospitals. I believe out of 30 that I can remember, one young lady said that, oh, you know what she said? She was from Louisiana. They only had one doctor there. And that one doctor took care of all of her family. So she was pretty satisfied because he knew them. But the rest of them did not have really good stories or feelings or jump out there. If I remember, Teresa, I don't remember any of them jumping out and saying they had the best care. Next slide, please. So I asked them these questions. How do you define prenatal and birthing support? What would you do different in your next pregnancy? What do you recommend to families and friends about birthing choices? Were you told about all the options to make during your pregnancy? Those are really quick, very good questions for especially some of the cultural communities that have had a history of doing pregnancies in a certain way, and a lot of them were done in a very natural setting, in a very natural way. And what has happened is and I say we because we're all in this, feeling that we know what's best. We were like, you go to a doctor and you go in the hospital and you have this big. I remember having my daughter very hard pregnancies for me. Shaking, I was so cold. No one, like someone said, well, that's just what happens after you have a baby, but needing them to take care and to know that I was a real person, not just laying there on the bed. I mean, relationships are important. And I want you to go to the next slide, please. Drake. Okay. I said his name right. So they went into small group discussions. Remember I said some of them, like, I believe the youngest there was 15. So they struggled on some of the questions like, what do you mean? But majority of them were able to get through talking about how would you design your own healthcare plan? Then how, who do you want involved in your support system? And then we asked them, what would an intervention plan look like if you were in an unhealthy environment? And then we talked about, is mental stability important to you? Next slide, please. Let's see what okay, so I ended that. I want to go to the next slide. Next slide. Do you have all my slides? Oh, I know. No, I have something I need to say. So I'm going to ask you to go to slide. I have some side slide discussions here I'm going to go through, which were.
Sameerah, can I ask a question
Sure.
before you leave this slide?
Absolutely.
It's first of all, just sort of, and I don't want to interrupt your presentation, but since you're sort of in a bit of a break, it's just interesting because so much of this rings true. Early on, we were talking about prenatal care for women in general that maybe using substances, opioids, and feeling unwelcome or judged, and within hospital settings or clinic settings, and how the outcomes for their babies were much worse. And it just I'm talking out loud without a fully crystallized thought, but that's been sort of an ongoing theme around that, as well as ACEs, what you're talking about as well, and the connections to later.
Well, that's one of the slides I'm bringing up now.
Okay, no, that's great. So it's intersecting with our other ones, but the one, stay away from long-term trauma, step 3. So are these, if we understand these steps, are these steps you go over with the young women that you're mentoring or meeting with? Step 1. And
that's what we did with this group.
Okay.
There'll be another group and then another group up at Red Lake. So forms, those are the questions that I've used, and I probably will be doing some changes, but yes, let me try this. I don't know if he can let me share. Sure. This is just the quick notes. One of the things that we are doing at Wilder, the directors and the managers are going through a book called Switch, and it's How to Change Things. It's by Chip and Dan Heath. And I read it, and what has just jumped out at me still, that how I like to look at AABC and projects is that we can function as the elephant, which is the emotional side of a situation, charging straight ahead, or we can be the rider, the rational side of a situation, seated above the elephant and keen on who is right ahead and committed to the service needed. Both of these roles can be enormous strengths or enormous weaknesses. AABC and projects has to be skilled at using both the emotional side and the rational side, starting by listening before moving forward to community. Most importantly, honoring the gift of community to navigate our projects with the intent of bringing change and serving families. Partnership is very valued. The work is hard and complex. That's the way I like to look at our work. So the work comes in all different ways. I never would have thought that I would want to go into, looking into what is going on in the prisons where there is a doula project. And then I'm listening to some of the stories, and it's like, okay, there's some issues and there's some policy issues, and we need to lean in, at least in a think tank, to say, what are the issues? Where can this go? And then start looking at that with doula servicing. And that's kind of what it's about in doulas, and writing in our curriculums a piece on not only the mental health, but incarceration, what birthing incarcerated, because I think everybody knows the mother is chained to the bed while she's delivering. So think about that, you women who have given birth and gone through the process, what that is like, being chained to a bed, giving birth to a baby. What does that do? Really, that social determinants of health, all those pieces, what is happening with that baby in the womb? Okay, next slide. So I also want to say, I know you guys know this too, but that ACEs I'm very careful. So those 30 mothers that were there, we did not give them the ACE test. One, somebody who's pregnant shouldn't be taking the ACE test, because we don't know what that triggers. And again, that stress, what it triggers, affects the mother and the baby. So I'm very careful with that. Most of us that are BIPOC, we live in it every day. We live in dealing with the ACEs every day at a different degree of, we know everybody can be, it doesn't matter. It's not about your race. It's not about your job. It's not about your health insurance. ACEs in a home can happen to every culture. It's just like if you have ACEs and then you have to deal with racism, it's a double whammy. Next slide, please. Okay. So when you reflect on my statement from that slide 3, how to change things, how to be a elephant or a rider, tell me what you think about that. How do you feel that you work? Or how do you think you would change things? Are you the elephant or are you the rider? Are you going on emotion? Are you going on rational thinking when you're dealing with the client or students or your family? We all got to check that. So somebody tell me something here. I'm going to go in and see. She said, here is the book mentioned, How to Change Things When Change is Hard. That's a good book. Or you can go to Switch. If you're doing, Switch is the name of the book too. If you're doing, thinking about some maybe larger or smaller tasks, you can have that discussion. I have not read, Goodreads is just where you can go to get the book. Is that right?
You know, I just Googled it. I'll have Drake take a look afterwards. The best way to find it. That's just was the first one that came up. You know, and you're right. It's called Switch. I missed that part. And then that's the sub. Okay. How to change things when change is hard.
Okay. Does anybody want to just say what they think, how they think they operate? Okay, we can keep moving. Next slide, please. So here's the voices from the mothers of those 30 young women in the room. And this is what they said. They would prefer not using a doula. My mama is all I need. Next time I'm going to go to prenatal appointments. So we had someone in the room. I walked by her. I was talking to her, matter of fact, and that's what she kind of whispered to me. Another mother said, don't let them give you fentanyl. I'm still not right. I think it was 2 of them were talking back and forth. And one of them says, sometimes they don't even ask you. Another woman said, I need to know about postpartum depression, because we talked about how different cultures deal with mental health. And she was not free to go or even have that discussion. If people say, well, that's all that happens. That's what happened to me. Nurse came in, I was sitting in the middle of the bed, I was crying. She said, oh, you're just having a cry. Well, I was really kind of going into postpartum depression. I didn't know what the heck was going on. So we need to talk to them more. And I said, none of you sit in in darkness. Don't go to that dark place. Go get help. Well, then one of the young girls said, but the staff doesn't listen to us. So then so that we didn't have, because staff was in the room too. I was basically like, okay, that's not going to be your excuse. There's other people. If your staff doesn't help you, I want you to go help. Do not sit in darkness. Give me a call if you need to. Okay. So I hope the staff listened to her. And then I believe it was still her again that said there's no one to talk to. Several said, this knocked me. I was just like, what? Several said, I don't have a doctor or insurance. I'm like, what is going on? So if they don't have a doctor or insurance, they're not going for prenatal. Shame on somebody. I don't get it. I think me and Teresa both were like, why not? There's Minsure or what's going on? So we have some serious issues going on. Another one said, I wanted an ultrasound and couldn't get one. Another one said, we need to go to persons that will not cast judgment. Another one said, we need help with the everyday food, housing, and transportation. These are your teens in high school talking, right? This shows some huge gaps. I think that's my last slide. Is that right?
Yeah, that's correct. Yeah, I can head back to our other slides here.
Right. So that's all I wanted to just share, those last statements of communication. So I'm done. I think, did I make my time or did I go over?
You did just fine, Sameerah. No, just fine. We then do a family story at the end, but you did just fine. Thank you so much. It was just filled with such good information. And thank you for bringing examples from the mothers that you work with. That it just makes it really powerful to hear their voices. I guess, we have a group here of primarily early intervention providers, but I see we have an OT and some different, I think we have teachers here too. Are there just any takeaways as you think about them working with families, some of whom may be experiencing addiction? I mean, I think one thing we take away, I think with all of our presenters is helping them to feel welcome when you're giving, so be it healthcare, be it education, be supportive, put judgment aside, open your mind. I mean, what are some other tips? I'm trying to we're near the end of our series and I'm trying to collect some of these common themes that we have. What advice can you impart on us before we head into our family story and working with families?
Well, first I want to say, I'm not an expert. I always look at myself as a catalyst and that I call in the experts. And so I'm always learning. And I think that if we all look at it, that we're learning, it doesn't matter what our job titles are, what our degrees are, to come real to the community, because the community can smell when you're not being authentic. And you have to bring your authentic self. And you have to, even with the teen moms, there were times when I might have thought they were stuck in answering questions. And so I'm not going to jump out there and answer it for them. That's what probably their moms do or somebody does. And so I said to them, I'm not looking at you guys as teens today. I said, I'm looking at you as mothers. So I think it's really important to bring your authentic self. They're not looking for us to be a friend. They're just looking for us to accept them where they are. And that's the best thing that I believe we can do for our community, is meet them where they are, and not feel that we're bigger than them, because we're really not. We all go to the bathroom, we all brush our teeth, we all do all of those, everyday things. So just be real. And that's all I can say.
No, thank you. Thank you. We really appreciate it. Thank you for sharing with us. It's just was great to have you back. And I think with that, we're going to switch into our family story. You're welcome to stay, Sameerah, but you're also, welcome to hop off too if you want to go enjoy the snow. Look at it out the window.
Well, I really do have to get to another project, if that's okay with everybody.
No problem. And your email's right there if anyone wants to reach out. Thank you so much. It was nice to see you again. It was nice to see you again, Teresa. And
we're getting thank yous in the chat too from Dana and Wendy. So many thanks from everyone here.
Thank you, Sameerah.
Thank you, everybody. I enjoyed.
Yes, thank you. Bye-bye. All right. So thank you, everybody. And thank you for your good feedback and participation. It's interesting to see, but not surprising, some common themes across our presenters. So I appreciate that. All right, we'll quickly do the family story. I will read it. This was actually written by, for those of you who were on the presentation last week about positive behavior supports, by Dr. Simasek. So she created several for me. So this was nice. So our case study, the topic areas we're going to talk about is trauma, or we've had several speakers talk about ACEs, social determinants, foster care, addiction. We'll also be talking about developmentally language development and sensory seeking. The age of the child is 48 months, which is 4 years. And the setting of this case will be foster home with foster brother who is 1 year older. She does a nice job of pre-setting some of the themes we'll talk about. Okay, so all of you can read it, but I also can read it. The patient is a male who lives with his foster parents and foster brother who is 1 year older. The patient has a lot of enthusiasm and a big personality. Placed with his foster family when he was age 2. And I apologize, I would use the word child instead of patient. I'm going to replace child with patient. Had 1 foster placement prior. Biological mother and father both have a history of drug use, incarceration, and homelessness. There's very little medical info about the child that is known by the foster family. At 3, the child was still receiving early intervention services through childcare since he's not enrolled in public preschool. He receives OT, occupational therapy, and developmental intervention. He's attended the same childcare program since he was placed with his foster or adoptive family. He did stay home sometimes during spring, summer during COVID, but is back to full-time childcare. The childcare staff have extensive experience working with children impacted by trauma, and the teacher-child ratio is very low. That's good. The child, I'm reading literally, and his foster parents attend PCIT on a regular basis. PCIT.
Parent-child, I think it's parent-child interaction
training. Yes, parent-child interaction training. I was thinking of it in a medical context. Thank you, Drake. Thank you so much. That's why we have teamwork here. All right, strengths. The strengths the child brings: a strong attachment with foster parents and brother. The foster parents implement interventions they learn. The foster parents are experienced with the foster care system, and the foster parents are eager for all intervention support. So those are strengths. Some barriers, and we see this, it can be a strength, but it can also be a challenge. The child has visits with biological parents and is not consistently able to occur for a variety of factors. The child may experience behavioral and likely emotional challenges for 1 to 3 days following these visits. The change in routine and services due to COVID is another factor for this child. Okay. So the primary concerns for the child are speech language, like we're thinking of this almost as a referral, sensory seeking, safety and compliance, and routines. Bedtime is especially difficult with tantrums and night terrors. And family concerns. The family is sharing behavioral concerns, as we talked about last week: tantrums, not responding to instructions. This is expressed by childcare on a regular basis, and safety, keeping all family members safe and also keeping child safe. What is the best placement for the child? And seeking evaluation for autism and ADHD. Probably clinical referral. All right. So our breakout group questions: how does the family and service providers help to support the child to feel safe? How to support the child leading up to and following the visits with their biological family. It's something they want to encourage, but it also has challenges. So some strategies around that would be helpful. What strategies and resources can support the child with developmental needs, including communication and behavioral issues, such as responding to instructions, safety in the community, and reductions in challenging behavior? And then 3, how should the family go about obtaining services to support the child with preschool services ending soon?